coming. I'm very much welcome and happy to welcome you here on behalf of W3D and of course our co-sponsors. I'm very glad to see them here in the room as well, especially African Union. Thank you so much, and also Dr. America and Turkish present and Santiago. Today we're here to kind of shed light on the missing link, trauma-informed guidelines to transform substance use disorder practices. And we're joined by an incredible panel of experts that will dive into the importance of integrating trauma in SED services while providing guidelines and best practices. And we did mention it a little bit before, but we do see a little bit of a gender disbalance here, of more women than males, but I'm very glad that even the men decided to join us here today because it's an issue that definitely is for all genders, not just women. The reason why we're holding this today is because in a recent webinar on Orange Day in 2024, we understood that the lack of such systematic integration of trauma is not there. It was highlighted by research that is quite missing. So to answer your question, why are we still addressing it? Because we do talk a lot about trauma-informed SED services, is because there's one thing of it being informed or one knowing about the need for the informed trauma-informed services, but the actual implementation of it is often lacking. So we are happy that you joined us here today and to kind of discover more about this issue. And without further ado, this is just one step in our advocacy, to be honest. There's going to be something very exciting at the end of the side event, some announcement. So with this cliffhanger, please. I would like to introduce our first speaker, Dr. Suarez Ordonez. She's a licensed clinical psychologist with extensive experience in trauma, substance use disorder research, and capacity building. Thank you so much. The floor is yours.
Thank you. Welcome. Okay, so I have a question. First, we need to do this interactive. I want everyone to interact with us. Do you need like a power drink in the morning? I know you do because you drink a lot of coffee. But what about the rest? Yes. Yeah, you need a Coke, of course. I know. Okay, so just for the 1 moment, imagine you are in your kitchen, you're preparing your coffee, and you only have 1 spoon, okay? Something happens, and the spoon bends like this. What would you do? Would you use it to stir the coffee, or you would be immediately trying to fix it? What would you do? Fix it. We try to fix it, right? So it's weird because in everyday life, we are all the time trying to fix little things. But when it comes to our brain health, mental health, and our body, we do nothing. And actually our brain, our health, and our body, as the spoon, changes, rewires, and breaks with trauma. So we are talking about the missing link. Let's see why. This community has done incredible work to fight substance use disorders. We have incredible organizations here, the African Union is here. However, we do have some not good numbers. 20%, we have an increase of 20% of people using drugs in the last decade. So this needs to raise a question. We need to ask ourselves, what is happening? What are we missing? So I asked myself, okay, so this is increasing. What else is increasing in the world? What is something that people with substance use disorders or people that are using drugs have in common? And many of us as well. Traumatic experiences, unfortunately. Look at this number. 70% of the global population experience lifetime trauma. 70%. What is on the rise? 1 in 3 women experience physical or sexual abuse. 1 in 11 men and boys have experienced sexual abuse. When it's physical abuse, the numbers are even worse. Drug trafficking is on the rise. Armed conflicts are on the rise. So I know this is a bold statement, but I do think we're in a pandemic of traumatic experiences.
Absolutely.
Yes?
Absolutely.
Okay, good. Thank you.
Yes,
I
absolutely.
like this interaction. So why is this important for us? We are at CND, so why are we talking about this? the numbers are very, very clear. Between 75% and 95% of people with substance use disorder report experiencing trauma. Women in treatment is even worse, up to 98%. That's a number, huh? So last year, I worked with some colleagues and we published a global survey that you can look at in addictology. 800 providers we surveyed across 82 countries. So if it says 0 and 2, it's not correct. So it's 882 countries. We asked about certain things. One was trauma, and 98% said, hey, I do want to receive training on trauma because I do acknowledge that trauma is essential for the development and the outcome of substance use disorders. But then we ask, okay, what are you doing? Are you including trauma? But this is the number that's shocking. 69.9% of the providers do not use any standardized tool to screen or assess trauma or PTSD. So what's the meaning of this? If we don't screen, we don't assess. And if we don't assess, we don't treat. If we don't treat, we cannot recover. So what is happening here? Maybe what we need to do is to change the narrative. So remember what changed the narrative with addiction back in the days? So it was neuroscience that appeared and said, addiction changes the brain, it rewired it. And since then, we stopped looking at people using drugs as junkies, as people that were unwilling to change, and we even changed how we treat them, right? So let's do it right here, right now in this room. Trauma rewires the brain just as addiction does. It's exactly the same, okay? So this picture, I love it because this is some pictures of the actual footage of a video of neurons connecting each other. This is neuroplasticity. This is how the brain connects and create new pathways. This is what happens when the brain rewires itself. We have good neuroplasticity. That is, when we grow, we learn new things, but we also have bad neuroplasticity. And that is trauma. And this is one of the best definitions I found. And listen to this. What is being traumatized? It means continue to organize your life as if the trauma were still going on, unchanged and immutable, as if every new encounter event is contaminated by the past. Listen to this. The trauma were still going on. Okay? So how this happens? Let's do something together again. So, have you ever had a moment that was so stressful, so emotionally overwhelming, like you just said, I just can't. I just can't. Have you? I know you have. Just guessing. I know you do as well. Do you?
Yes.
Yeah. Okay. So, but then you go back home and you just said, okay, I said some very, very bad things. How and why did I act that way, right? Moments later, you come back and you say, what have I done? Yes? Okay. So the good thing is science here back us up. Because how does the brain works? So imagine you're here and a bear just comes in the room. What will happen? What will do? This, not thinking, not talking, this. What am I doing? I'm getting bigger. I'm actually getting bigger, right? Because what happened? My eyes saw the bear. My amygdala processed and said, watch out, because you are in huge danger. You're going to die. So I just, without thinking, I prepare to fight or flight. So in no time, we become Superman or Wonder Woman. I just added Superman because that's two women, they took away. So it's true. So we do become this. But the thing is that in this moment, every resource in our body, in our brain, goes to two places. The limbic system, because we need to fight or flight, and to our muscles, who are down very, very low. So there's a part of our brain that has no blood flow and no oxygen. That is the prefrontal cortex. That is the one that is responsible for what? For thinking. So, see, we cannot think under stressful situations. But in a healthy brain, what happens is that you survive, you fight or flight, you kill the bear, let's say, and then go back to being Clark Kent. You think again, right? And this is a microseconds. What happens in trauma? You never get back to being Clark Kent. Why? Because when we have stressful situations and traumatic events, especially when we are held down, we cannot fight and we cannot flight, right? So we are unsuccessful, and our brain just thinks what? This is not working. You're not safe. So it keeps going. A healthy brain without trauma is a body that can self-regulate itself. But when we have trauma, we said the prefrontal cortex is basically out of the office, right? So we have a body, the connection with the body, that is absolutely unbalanced all the time, because we don't have the prefrontal cortex that says, this happened 30 years ago. You're safe now. Nothing has happened. Amy is not a bear. It's Amy, right? But we can't do that. And worst case scenario, we feel nothing at all. So the first case scenario is, okay, so we are resilient. We can go through trauma. I can process it correctly. I get stuck on fight or flight, or I go in total collapse. And this is very interesting because this is the last resource we have when we are in such a situation that we really feel that we can do anything to save us. We will just stay still. Have you watched any movies that the girl just stays still and let things happen? It went to total collapse. And when you get stuck in this, you can go back and forth the whole life, fight or flight, or collapse the whole life. So with this in mind, we need to address this in trauma. We need to put neuroplasticity in action, in prevention, in treatment, and in every recovery efforts. Now, what are we doing? We are using top-down interventions. Top-down means we are targeting the prefrontal cortex. We are trying to talk with our patients with trauma. And what happens when we are trying to screen and we say, okay, what happened to you? Tell me about it. Do they tell us about it? Usually they don't, because we are asking them to rationalize things. So what evidence is saying is we need to combine top-down interventions with bottom-up interventions. These are the ones that regulate the nervous system. First, we need to regulate the nervous system so the body can think, can feel safe, and can think. So we need to combine bottom-up interventions with top-down interventions. This is what we are missing, and this is what we need to do, both in prevention, treatment, and in recovery. So I know I don't have any more time, but I do want to say that something is coming because we know there's a gap, and it will be presented in 20 minutes. So please stay tuned. Thank you very much.
Thank you so much, Rocio, and thank you for visualizing trauma for us. I think it's oftentimes is a term that we know of, but again, we don't know it if we haven't experienced it, and even if we experienced it, we don't even always know what's happening to us. So thank you so much for visualizing that for us. And with trauma, mental health is, of course, interlinked. So I would like to give that bridge to then give Anya the word to kind of elaborate on this new WHO special initiative on mental health. But before that, I would like to introduce you. Of course, she is the unit head drugs, alcohol, and addictive behaviors in the Department of Mental Health, Brain Health, and Substance Use at the World Health Organization. The bio is much more elaborate than that, but The floor is yours. Thank you for joining.
Thank you so much for coming.
Of course.
So thanks so much for having us. And I mean, as I'll present a bit on WHO Special Initiative on Mental Health, maybe just for the context, it's good to know that I just joined WHO 4 weeks ago, but the Special Initiative is already existing longer. So especially my first slides are really based on the work that colleagues are doing in the department, and it's not so much, so to say, my direct work, right? And what I wanted to talk, and I will talk about, is also kind of options on how substance use can eventually be integrated more in the WHO Special Initiative for mental health. And I think if you can use the QR code, it will also take you to a website where there is more information about the special initiative. So the vision of it is that all people achieve the highest standard of mental health and well-being. And you can also see the goal there. So I was already worried if I should have used my glasses to read it better. Maybe I need to. So it's to ensure access to services for mental, neurological, and substance use conditions. And the target was 400 million more people, right? And a number of strategic actions kind of were involved in it. And you can see on screen that there are the 9 countries that joined the special initiative from different regions of the world. And so there are kind of a number of strategies involved with the special initiative for mental health that are mutually reinforcing. And I think one is especially important. It's a comprehensive mental health action plan, 2013 to 2030. And these action plans are usually approved by the World Health Assembly. So there is backup from WHO member states. And so these are the achievements to date across 9 countries. So as I said, I'm not taking credit for it. That's the work of our colleagues who have worked across all of these countries mentioned before. So up to now, kind of around 1 million children and adults have received treatment for mental, neurological, and substance use conditions, most for the first time in the framework, let's say, and with obviously the work done by the countries involved in the special initiative. More than 65 million people have access to mental health services in their communities in the countries, and 35,000 and more individuals have been trained in practices that relate to mental health and psychosocial support. And there is, so to say, beyond these figures, a lot of achievements also, let's say, on the policy or practice level. I will just, for example, there have been mental health laws aligned much more to include human rights principles, or kind of psychotropic medicines, which, as we all know, are often not available in many places, even if they are on the essential list of medicines. So those could be introduced. So there is a lot of work which goes really beyond training and capacity building. There's really a lot of work that has happened at the policy and legal level, and therefore kind of much more can have population-wide effects if, then these laws really get implemented as well. No new kind of emergency preparedness plans have been made that included mental health and so on. So, and I think one of the learnings from the Special Mental Health Initiative, and especially in this climate where resources are so scarce as maybe not for a long time, one of the kind of successes has been that it was a multi-year initiative with predictable funding. So there could be good planning done for and with all the countries, and that they could really look into the return of investment from the interventions made in the special initiative. So one of the things you saw on all the other slides, that substance use, of course, and substance use conditions were in principle also included. As a matter of fact, I think in most of the countries, even though some of the countries raised it as a priority, the funding that had been received for the special initiative nevertheless was often not enough to also include kind of addressing substance use. So I mean, when I, now you're kind of the alcohol, drugs, addictive behaviors unit, we're of course much advocating for a stronger emphasis, and there's also much of interest, right, to make substance use stronger in the framework also of the special initiative on mental health. And you all know, of course, that disorders due to substance use are very much mental health disorders as well, and classified as such in the international classification of diseases. And I mean, the epidemiology, I think many of you have mentioned, right? In here at the Commission on Narcotic Drugs, we hear a lot, of course, about prevalence rates and number of people using internationally controlled substances, around 275 million people and counting, and around 11 million people injecting drugs. And WHO in 2019 had attributed that there are close to, I think the numbers are even higher, close to 600,000 deaths attributable to drug use. And we're at the moment updating these numbers, so soon we'll have the 2023 numbers, which is, to put in perspective, right, it's estimated that 2.3 billion people are using alcohol, and 283 million people are living with alcohol use disorders, right? So there are more people living with alcohol use disorders than people using drugs, right? Just to get the perspectives, so to say, also in there. So in the comorbidities between substance use disorders, and when I say substance use disorders, I mean all psychoactive substances, right? And mental health conditions have been looked at a lot, and it's estimated, depending different studies, that between 50 to 80% of people with substance use disorders also have other mental health disorders, and that's of course could be due to common risk factors, or that, so to say, the mental health condition increases the risk for substance use disorder, or vice versa. And then people that have kind of both conditions, substance use and mental health disorders, have also the risk of numerous other negative health outcomes, such as emergency admissions and psychiatric hospitalizations. The risk to symptom reoccurrence and relapse to substance use is higher. Also, people die earlier, including by suicide, and obviously the stigma, which is with mental health disorders or with substance use disorders, then also gets potentialized. So so the ideas that we have of substance use could be integrated more in the special initiative, and there are a lot of tools available, right, that would make this easy. So on one side, that we have assessments that look at both, so that really look at mental health disorders, including substance use disorders, and not excluding, which is something that actually too often happens, right? And then to advocate and build the political will, so that also we can have actions at community level, make substance use services available to close the prevailing treatment gap, integrated not only with mental health care, but also broadly in primary care levels. And the WHO MH-GAP package is really designed to do that. And then as needed, and maybe also with continuing and postgraduate education, include also more offers and specialized services. In a similar way, you know, also we need to include both mental health and substance use more in primary prevention, and I see your t-shirt, right? Prevention being better than the cure, and I think, I mean, we know pretty well that addressing mental health disorders early on kind of also has an impact on a reduction in the development of substance use disorders in later life, right? So there is a clear linkage to address one. And with that, these were just a few considerations, and hopefully we got you interested in the special initiative. But hopefully also if you're in one of those countries and so on, very happy also to always have your advocacy to include substance use there even more than it is already. With that, thank you.
Thank you so much, and congratulations on the initiative as well. I mean, even though it has been around for some time, I think it's always good to kind of put it in light again, because sometimes it might be forgotten or not seen. And great to see that some countries have collaborated as well. And thank you for highlighting the connection with human rights and the mental health. That's something that we always want to highlight as well. And it's also good to see, as you said, there's, and was mentioned by also earlier on, the emergencies that is happening around the world right now, that there is definitely a need to kind of include mental health in the trauma responses in that. So thank you for that. So with that, I want to move on to the next speaker, Sanita Suhartono from UNDOC. She is the Associate Program Officer, Prevention, Treatment and Rehabilitation Section. Very thank you for joining us and elaborating a little bit on the treatment and mental health.
Yeah, thank you so much. Thank you also for inviting us to the organizers and accommodating this presentation. So I will be speaking about trauma-informed treatment and care for people with drug use disorders in terms of policies, guidance, and practices. I just want to remind all of you that already in 1985, member states have agreed to the at the General Assembly to join the United Nations Standards Minimum Rules for the Administration of Juvenile Justice, or short, the Beijing Rules, where it was highlighted that it would be necessary to support young persons suffering from the trauma related to alcohol use, drug use, or mental health disorders, which is important for our topic today. Other than that, member states have also agreed in 2010 at the General Assembly again to commit to the United Nations rules for the treatment of women prisoners and non-custodial measures for women offenders, or the Bangkok Rules, to provide gender-sensitive trauma-informed women-only substance use disorder treatment programs in the community. And at the Commission on Narcotic Drugs in 2012, member states have also endorsed the Resolution 55.5 on promoting strategies and measures addressing specific needs of women in the context of comprehensive and integrated drug demand reduction programs and strategies, where member states were invited to recommend and take action to support the needs of women who have experienced sexual and other violent trauma related to drug use or drug use disorders. Member states have been also reminded again to take into account the specific needs of women, including parental responsibilities and recovery from trauma related to drug use or drug use disorders suffered as a result of sexual or other forms of violence. We have already heard a lot about the data that it was presented in the World Drug Report 2024. I would like to highlight here that unfortunately, only 1 in 11 people globally have access to treatment, and this is worse when it comes to women. Here you can see, although men are still more likely to use drugs than women, the number for women accessing treatment is more limited to the global number, and there are obviously regional differences. In terms of risk and protective factors for the initiation of drug use, I wanted to highlight here that mental health problems and trauma and adverse childhood adversity was also highlighted in the World Drug Report 2023. And in terms of guidance, especially here at the CND, the international standards for the treatment of drug use disorders has been proven to be a useful tool and referenced also in a lot of resolutions. And here you can see that the standards have highlighted as well that the extensive and supportive environment the patients experience in residential treatment can offer an appropriate response to trauma. And I will continue. So the standards also recommend when developing treatment plans to include a comprehensive assessment that was also mentioned by Anya before. And here I would like to highlight that mental health, including trauma and abuse history, should be highlighted in the assessment. In terms of evidence-based psychosocial interventions for people with drug use disorders, the standards have listed a lot of psychosocial interventions, but here I would like to highlight also that trauma-focused cognitive behavioral therapy was recommended. And we have also heard from Anya the importance of the treatment of co-occurring psychiatric and physical health conditions when offering treatment for people with drug use disorders. And here it was also highlighted that post-traumatic stress disorders may cause a complicated or a disruption in the engagement in treatment. So this should be also taken into consideration. And here I would just like to highlight that UNODC has presented a conference room paper on comorbidities in drug use disorders at the Commission on Narcotic Drugs in 2022, where women with substance use disorders have been reported to have higher rates of post-traumatic stress disorder and may also have experienced childhood adversity. So the topic of including treatment of comorbidities for people with drug use disorders is highly relevant. Continuing with the guidance from the standards also highlight the need of including comprehensive women-centered treatment, right? And here I would like to highlight again that the standards recommend trauma-informed group and individual treatment practices, including childcare and parenting education. The standards have also included the need to take into consideration children and adolescents with substance use disorders. And here I would like to highlight that children are often victims of neglect and physical, sexual, and emotional abuse. So they need, they're more exposed to risk factors and have fewer protective factors. When it comes to treatment in prison settings, the standards have also highlighted the need to address trauma among women who have survived harmful events. And here I would like to remind all of you again the Bank of Rules, which this year will celebrate the 15 years of anniversary as well. Before I end my presentation, I just wanted to highlight some activities that UNODC is supporting that address trauma in people with drug use disorders. So here you can see some capacity building initiatives, specifically for practitioners working with adolescents with drug use disorders, including those in contact with the criminal justice system. And here, UNODC is also part of interagency standing committee working in humanitarian settings and displaced populations. And we have, together with WHO and UNHCR, highlighted the training materials specifically for community workers working in humanitarian settings. And lastly, I just wanted to show as well that we are, of course, supporting the encouragement or the promotion of treatment for women with drug use disorders and including as well women with lived experience in these activities. Yeah, so this is it. With this, I thank you, and if you have any questions, of course, I'll be available.
Thank you so much for highlighting all the different work that we have been doing in order to incorporate trauma on an international level and also to present that to governments and national agencies. And thank you for being an advocate for trauma and presenting so many different reports as well in different aspects. I think that's definitely essential in order to also understand the necessity of trauma and what can be behind. So the next speaker I would like to introduce is my dear colleague Azia Ashraf. She is a devoted professional with over 18 years of expertise in addressing drug addiction treatment, rehabilitation, prevention, and recovery. Also, she has a very impressive resume, but I would like to give her the floor, to spend time on the presentation.
Thank you very much, Krishna. Good morning, ladies and gentlemen. Today I'm going to talk about healing beyond addiction and bridging the gap in trauma-informed care for women in Pakistan. And you know why I come. So that is the beautiful map of my country, Pakistan, which is situated in South Asia, a country with almost 255 million people. This map is also a very important value. We share a long forest border with Afghanistan, and Afghanistan is world's largest illicit drug producer. So Pakistan, unfortunately, is a transit corridor as well as consumer of illicit Afghan drugs. As per the survey conducted by the UNODC in 2013, there were around 6.7 million illicit drug users, and women constituted about 1.5 million drug users. And UNODC reported that this is underreported data. In that survey, women were found to be using prescription opioids, tranquilizers and sedatives, and more amphetamine type substances. In that survey, generally, not just specific to the women, There were amphetamine type users, they were around 49,000. But currently, ice is a huge pandemic in my country. It is like kind of an ice surge in Pakistan. You can see, and most importantly, it is affecting young girls and boys in educational institutions a lot, and particularly young girls. And we do not have enough spaces to treat them. So I'll briefly touch the trauma and addiction because it's already touched by Rosho and Anya and Sanita. So we understand that there is a trauma is associated with higher risk of later substance use and vice versa. Substance use predisposing people to higher rates of trauma. Both gender, they are vulnerable to the substance use disorder. But women, they have more severe psychiatric, medical, and employment issues. And there is increased risk for violence, sexual, physical, and emotional abuse. And trauma and socio-cultural stressors, they aggravate the situation for the women. Unfortunately, domestic violence and sexual abuse is alarmingly increasing in my country. And there is some sort of socio-cultural normalization of spousal and parental abuse. And that is so unfortunate, but it exists. And there is attribution of symptoms of trauma to more magic and evil spirit. So they take women to the so-called faith-based healers who try to do everything to get the evil spirit out of their bodies, making them more, even traumatizing them more. And unfortunately, there is a victim blame. These young women, they lost their life, and still they were blamed by why they choose the substance using partner. Why? And they were like this, they were like them, they were wearing dresses like this, and they were wearing like this, blah blah blah. Unfortunately, there is a common trend of victim blame. And how is the treatment capacity in my country? As per the UNODC survey, there were around 4.25 million people who were with substance use disorder. When we say that substance use disorder, it means that they require some sort of a structured treatment, and only 30,000 people in a year could get treatment. And all the treatment, they are male-oriented. So no specific spaces for the female who are suffering from substance use disorder. So female, even if they are able to get treatment somehow, they are overlooked in the treatment for the little or no consideration of trauma that actually fuels addiction. So the women, like it means that the lack of gender sensitive trauma informed care services mean that women are, they fear seeking help due to stigma, lack of safety, and most importantly, the pain of re-experiencing abuse, or fear of re-experiencing abuse in the treatment setting. And unfortunately, there is dearth of expertise in the field as well. And what happens that the absence of trauma-informed care results in higher dropout rates, multiple relapses, and poor treatment outcomes for the women. We cannot change future without changing the past. So trauma-informed care is not optional. It is essential for breaking the cycle of addiction. What we are doing at Greenfield Hospital of Psychiatry to handle the situation. This is Greenfield Hospital of Psychiatry, where we provide evidence-based, gender-sensitive, culturally appropriate treatment to the young girls and women. And we ritually follow the 6 principles of the trauma-informed care. And we all know that principles. They are about like safety, gender-based violence, trustworthiness, peer support, collaboration, and mutuality, empowerment implies cultural, historical, and gender issues. I will not go into the details of those principles. I will just let you know how we are trying to implement those principles in our daily life. Most important is treatment environment matters, both the physical environment and the psychological environment for the woman. We see that women need to be approached from the complete context. Treatment should be approached from the complete context of the woman's life, like the relationship, their support system, their culture, ethnicity, everything is very much important. So we believe on creating an environment that fosters safety, dignity, and respect. An environment that actually creates healing. And there are 3 major components of the healing. Safety, that the staff has boundaries, clear boundaries. Most importantly, privacy and confidentiality is ensured. Mutuality, women are equal participants in the recovery, in the treatment, and focus is on empowerment of the women. And most importantly, availability, accessibility of the treatment for the women. So we ensure at Greenfield Hospital of Psychiatry the treatment is accessible and available, and it is tailored to the individual needs of the women, like if they need short-term treatment, long-term, outpatient, intensive outpatient, whatever they need is. And we try to keep our promises. We try with it. And we listen more to our patients than talking us. And we keep our patient well informed, like what is happening in the treatment, what are the goals of the treatment, what are the objectives of the treatment. We have a very good feedback system where we address complaints regularly. And if there is like, and we keep on doing the follow-up of the complaints narrated by the women. And we try to be helpful, the whole staff. It is not just the clinical staff. It is like the whole staff, from the executive staff to the administrative or support staff. Everybody tries to help the women. And definitely we try to create an environment where there is a respect, there is an unconditional positive record, no judgment for the women. And you know, when you are working with any treatment facility, you have a lot to do. And it is very important to remain patient. And that is like we try to follow at Greenfield Hospital of Psychiatry. And we do take extra steps if it is like favoring women, if it is helping them, like if they need childcare, if they need any legal support. And we try to create an environment of positivity, healing, compassion, empathy. And we train the staff member regularly in the trauma-informed care. And I will say it again, not just the clinical staff, all the support and administrative staff, they're being trained on it. And there is a constant supervision is provided to the staff member to deal with the vicarious trauma or the secondary trauma. And we understand that what it is called, like when you are working with the person having trauma, you feel the symptom. So constant supervision is being provided to the staff. We have a very beautiful recovery lounge. It is open, safe, free space for the women who are in recovery, who can talk with each other over a cup of tea, coffee. They come there, they paint, they do whatever they like to do. And we do a lot of psychoeducation of the family members. We build up support groups, we do family counseling, we do couple counseling. And we take care of the culture. It plays a lot of role while only dealing with substance use disorder, and when we talk about the trauma. In both cases, the culture plays a key role. So one just example is like in my culture, the people prefer that women should be treated by other women. They prefer. And most of the staff at the Greenfield Hospital of Psychiatry is women. You can see all the women. Directory have doctor, assistant psychologist, assistant psychologist, case manager, they're all women. We do have a gender balance. Or psychiatrist is male. So by creating trauma-informed care and compassionate environment, we promote post-traumatic growth. And these are the beautiful women from our recovery lounge doing different activities. And these are the paintings made by the women who are in recovery. And so from pain to pain, from wounds to wonder, every brushstroke is a story of resilience and hope. And we do a lot of advocacy at local level and at international level. I'm sorry, Roshi, I do not have a picture of you and Chantel. I am going to conclude my presentation with the last slide that trauma-informed care is not just a framework. It is a commitment to healing, empowerment, and transformation. By embracing these approach, we don't just heal wounds, we inspire hope, build resilience, and shape a future where recovery thrives. And thank you.
So much with this very much inspiring quote summarizing basically the whole event and the importance of it as well. It's very fascinating, and I think thank you for also showcasing the issue that is existing, but also that there is some good practices that are working, trying to fill some gap, even though you cannot fill the whole gap maybe, but you can start small with some, and hopefully that will expand to the wider area. So with that, I would like to hand over the word to Amy. Amy is our very much nice international president from WPD, but also the executive director of both Drug Free America Foundation and Safe Our Society from Drugs, which are both national non-profit organizations. Nice. There you go.
And the beauty of going last is, I really don't have much to add. Everybody has said a lot of great stuff, and I kind of forgot that I was even doing stuff because I was getting so involved in there. So mine will go fairly quickly, I think. But I'm going to focus on prevention. So we talked, we had some talk about mental health stuff. We talked about treatment. And so one of the things that we focus on a lot is prevention and recovery. So I'm going to focus the little time that I'll talk, because I'm going to skip over some of it on prevention. So we already talked about that substance use doesn't happen in isolation, that there's a lot of other things that talk about it. I won't go over the data because we've seen that already, but basically that the problem right now is that our traditional forms of prevention models, they don't address this. They focus heavily on substance availability and social pressures, but often fail to acknowledge trauma as a major risk factor. So we're not often addressing why this happened in the first place. We're just telling you how bad the drugs are and what they're doing to your physical and mental health, but not really addressing the key drivers that drove the substance use behaviors in the first place.
This is Amy, ladies and gentlemen.
I was listening to everything else, but I really wasn't paying attention to where I'm at in my slide. So I'll just keep talking and we'll see. So when we talk about trauma-informed care and prevention, what are we really talking about? So a trauma-informed approach recognizes the role of trauma in substance use and integrates the practices that employ trust, safety, and empowerment. Maybe that's in the slide somewhere. Maybe this is it. Okay. So I took just 4 key principles that kind of make up trauma-informed care for prevention to make it effective. So first, making sure that you're creating safety and trust so that individuals feel supported. And then second, empowerment, making sure that they have a choice. They're ensuring people feel that they have control over their own healing. Third, peer and community support, which fosters connection and resilience. And lastly, what we talked about, each of the speakers, I think, touched on this, is the cultural sensitivity, recognizing that trauma and recovery look different across different communities and demographics, not just in different regions of the world, but for example, I live in Florida, which is a pretty large state in the United States, and we have beach communities, we have rural communities, we have big cities, but even in Florida, it looks different just across our demographics. Might be on track now. So now I want to talk about how trauma-informed prevention strategies, how they can be implemented. So we can do it, okay, all right. So first in schools, looking at, the place where we have most of our youth in one place at the same time, but integrating social, emotional learning and mental health support in our education system and training our educators to recognize trauma-related behaviors and how to respond appropriately so that they can prevent youth from turning to substances as a coping mechanism. And we do talk about this a little bit. One of the groups that we partner with a lot, and Dave does too, one of my colleagues, is the Drug Endangered Children's Alliance. So teaching educators to kind of see what are some of the indicators that the kids in the school might be coming from a drug endangered environment. So expanding that to also include trauma. And so having educators, not that they already have enough on their plate, of course, but adding this to their professional development. Also in communities, community-led initiatives are also vital, creating safe spaces for young people to heal and find support. Sometimes that safe space often is not home. And so it might be school, it might be a playground, it might be the next door neighbor's house. So making sure that they have areas where they can do healthy activities, where they're less likely to engage in substance use, and having trauma-sensitive peer education and mentorship programs, teaching other youth how to talk to each other. And I know that there's a lot of programs that focus around suicide interventions. And if you have a friend express different things to you, what is it that you say? Because a lot of us might be caught off guard, even as adults, but especially as youth. So training youth, having that built into education systems. Also in the healthcare settings. When we embed trauma-informed screenings and counseling into primary care and prevention programs, we can address those risk factors often before they escalate. So as we move forward, how can we change things on a policy level? As a policy nerd, these are the things that I think a lot about. So to start, we have to shift from a punitive approach to a prevention approach. So policies that prioritize trauma over punitive responses, making sure that we're looking at that. Also that we invest in early intervention and prevention. So we've talked about that a lot at the CME. We've talked about, that's part of the Oviedo Declaration, prioritizing prevention funding, but making sure that we're investing early and making sure that includes trauma-sensitive education, family support, and mental health services and resources. And then coming together to make this global commitment. So oftentimes we talk about these things when we're here at these meetings in person, but then we go home and we kind of forget about them until next year, and we're scurrying to update our slides and think about how we can talk about these things. So making, encouraging those ongoing conversations with member states, encouraging conversations within our own NGO networks and stakeholders to make sure that we're integrating these policies and approaches into all of our prevention policies.
I didn't take it out.
Oh, well, and as has been talked about multiple times, there is a new initiative coming, and I think we're almost at that 20-minute mark. But the call to action is that, prevention must recognize trauma, substance abuse, the connection there. We have to acknowledge that. We have to make sure that we embed that into what we're doing. Those strategies have to be in education, healthcare, and also in policy, and that we're investing in this just as we're investing in long-term prevention, and that it's something that goes hand in hand. And with that, I think I'm turning it back to President. Yes, for the breaking news.
Thank you first. Thank you for highlighting the prevention aspect of it. Since we said trauma is something that needs to be integrated in all steps of the process of the continuum of care, and how Smith already said, the risk and protective factors, these are very much known, but how to implement them on the local and national level, as you gave some examples, training the teachers also more on trauma rather than, the other things as well. I think it's very important, and it's something we should bring home to our communities, our organizations we work with. So thank you so much for highlighting that. And yes, now it's for the final part of the side events, in which we are very much happy to share that we when setting up this side event, we thought, okay, this is one thing, the side event is important in our advocacy, but there's more after that. We cannot just go every side event and see every side event and trying to catch attention. And we were wondering ourselves, how can we improve our advocacy? How can we improve our services? How can we increase the understanding of trauma in our networks? And how can we expand the efforts that we're doing together? So as we're going to present this new initiative, we want you to be part of it. Some leaflets have already been put on the table, which are a little bit of a spoiler already. But I also want you to grab your phones, because we're going to post some more questions for you to also think why you should be involved. So please grab your phones. There will be a QR code on the screen now, and you can scan it, and then Rocio will. Yeah.
Oh, okay. All right. So do you have your phones? Everyone is on the poll. We're doing a poll now. Okay. So in one word, addressing trauma is, you just type, please, a nice word. Okay. I trust you guys. Addressing trauma is essential. Come on, vital. Okay. Necessary. Okay. What else? Come on, everybody do it. Mulka, you doing it? Why?
No fast typers.
Fundamental again. Okay, these are okay. Critical, important, human, home, helping, safe, people. Important. Okay, so the biggest ones are the ones that are having more answers. Everyone is answering? Okay. Come on, because this is going to be part of the initiative as well. Oh, essential is winning. Okay, so I think everyone in this room is agreeing on something. Oh, I don't know, necessary is just there. Oh my God, oh my God, this is your moment. I think we all agree on this, that addressing trauma is essential, that is necessary, that is critical, vital, important. Look at this. Innovative, that's a nice one, liberating. Okay, so this is a snapshot we're gonna use because this is something you are telling us what you think about. So we're gonna go to the last one. Are you ready? One more. You have the other one. What is the biggest challenge you face in addressing trauma and substance use disorder? You can pick as many as you want. Where I'm not seeing the result. Oh, here. Okay, so you select it and then you have to send it. Okay. Okay, so one of the so stigma and the misunderstanding of what trauma is winning. Lack of trauma training. We've seen this all the time, right? Limited evidence. Okay, we do have evidence-based resources apparently, but maybe we're not using them correctly. Limited policies. Okay, so it seems that no, it's moving. Okay. I need to have an answer. Okay, this is your final answer, guys. Are you done? Okay. No? Oh my God. No, okay, so this is the biggest challenge. Stigma and misunderstanding, and this is key. There's a big misunderstanding on trauma, and this is why we are here today. We are trying to change the narrative. It's not a woo-woo thing at all. It's a mental health, but not just, and I'm doing just because mental health is huge. It's not just a mental health, but a neurobiological issue as well. So we will need to work hard on stigma, on changing the narrative, in training, and on building more resources. And we can work on policies as well. So everything is aligned. And before I move to the presentation of what we have for you today, I need to acknowledge you. I'm sorry, I know you hate this, but I need to acknowledge Amy. Because I'm obsessed with this thing, with trauma. And I had a conversation with Cressida, and she's incredible as well. And then I talked with Amy, and they were both on board right away, and they gave these incredible ideas, and we are building an initiative. So, Amy, I adore you. Cressida, I adore you. So, this is it. So, Drug-Free America and WFAT is presenting this. I know Ron is also with us. So if you want to join, you can join. It's a trauma and substance use action force. And this is key, action force. We're not going to talk more, we're going to act on it. This is the difference. And I'm so happy we have one of the two most important organizations in the world here, so we can talk more about this. We have only one goal. Only one goal. We're not spreading our energy into many things. We are addressing the trauma gap in substance use disorders, prevention, treatment, and recovery efforts around the world. What do we want? We want to bring together professionals, organizations, policymakers to ensure that trauma is recognized and integrated in every effort in substance use disorders. And this is what we're going to do. Anyone say something? No?
I think I want to add, just to understand, like, it's not that they're trying to create anything new here, as you heard, there are incredible, already evidence-based reports out there on trauma as well. We know a lot about it. It's just the fact that we want to bridge that gap in implementation and the evidence that's out there. So we want to do that. So I'm so thank you, Anya, for joining. And we can continue to elaborate on that a little bit more.
How are we going to do this? We're changing the narrative. You said just before, this is a misunderstanding, and our efforts are going to be regarding changing the narrative of trauma. And we're trying to shape policy as well. Here we have an expert on that. So we are going to do advocacy and awareness, as you said. And we are very aligned with what they said we need, because we're going to train the global workforce as well. And we will develop practical resources. This is what providers around the world are telling and asking. I know this is important. I know this is here, but what do? I need to turn around and just pick up resources and just put it into practice. And this is one of our main goals. So we are building. We are just being born right now. So this is an international community. You can join. This is a moment, and you said it perfectly yesterday. So say it again.
I don't remember.
Oh my
Yes, ladies and gentlemen, but this is the beginning. This is yours. We're just kind of putting a logo on it and creating a space.
But we can do more than that.
Yeah, I mean, we're doing a little bit more, but we want you to tell us what you need. And so that we can help, present it, and we can help build it. And, it's yours from the ground floor. This is the very beginning, and we're creating it, for all of us, but we want you to tell us what you need. Like what do you need to address trauma in your communities? And kind of what we related it to was we were doing a lot of work around recovery and inclusive recovery cities, and we have all these people that are talking about recovery and inclusive things, but nobody knew what recovery capital was. So how do we move forward if we don't even know how to build recovery capital? So with this, if we're talking about trauma-informed care and everybody agrees that it needs to be included, well, how do we include it? And what does it mean? And what is the elevator speech? And what are a few things that I can build on? And so just having those easy resources that everybody can understand.
Okay, thank you. You rephrased it.
I know, it was better yesterday.
It was better. So this is a QR. We already have a website. Just join the initiative. You can talk to us. We can do a meeting, whatever you want to move us forward. And so we thought about this. So if trauma had a voice, you would say we cannot heal we cannot heal what you refuse to see, and it's true, right? So we need to look it right into their eyes. So thank you very much, and join the QR. Very good.
Thank you, and thank all the speakers again for joining us here today, and thank you for joining us as the important audience, because we can be here, but without audience, who do we talk to? So thank you so much for being here and being part of the impact. So good luck today.
Thank you.
I guess it's something that shared. You can't even get Pakistani women through the door.
Oh,
yeah.
They
just. And they've got the clinic there, basically.
Well, she was being sad to link up with me.